Hello, my name is Umar Mahmood. I'm Chief of Nuclear Medicine and Molecular Imaging at Massachusetts General Hospital in Boston, Massachusetts. It's a great honor and pleasure to be able to speak at the Pakistan Society of Nuclear Medicine. I only regret that I can't be there in person, and I truly hope to be in person in a future year. Today I'm going to be talking about precision imaging to guide cancer treatment. And what that really means is helping determine the right therapy and the right dose for each individual cancer patient. In terms of disclosures, I'm, in addition to my job at Massachusetts General Hospital, I'm a co-founder of Cytosite Biopharma, which focuses on immuno-oncology imaging. Since this is a nuclear medicine meeting, I thought I'd start by showing a picture that we see every day, which is fluorodeoxyglucose metabolic imaging for both detection and for response assessment. So on the patient on the left, a patient with ovarian cancer post-surgery with rising CA-125, the anatomic imaging, while having high spatial resolution, provides poor contrast between the tumor focus, shown in red, and the adjacent bowel loops. It's based on its difference in metabolic profile compared to the normal tissue metabolism that we can readily see the tumor focus. And on the right, we can see in a patient who has lymphoma that the FDG imaging provides an early assessment of treatment response. And that early imaging with early insight into treatment response often occurs before anatomic changes occur. So the question becomes, what is precision medicine? Why do we care? And how do we use nuclear medicine to help us answer questions surrounding precision medicine? And what precision medicine is really focused on is that we're all different. We have slightly different genes, or our environmental exposures are different, and our lifestyles are different. So the basic concept is that while we have many things in common, we also have things that make us individuals. And most medical treatments have been designed for the average patient. As a result of this one-size-fits-all approach, treatments can be very successful for some patients, but not for others. Now, patient heterogeneity has always existed, and many gains in clinical medicine over the last 50 years were achieved by medical insights that were uniformly applied to large patient groups. I believe many future gains will be achieved by fractionating patient populations into smaller and smaller groups. And the question is, why now? What are the drivers of relevancy? Why is precision medicine becoming such a hot topic today? And that's because we have more medically relevant data. We have a greater biological understanding of disease, especially in cancer. We have improved data analysis tools, and we have an increasing number of well-controlled clinical trials that provide outcome data so that we can, when we have additional input, we can use that to help optimize different dosing and different strategies. We also have more therapy choices. There are more novel classes of targeted therapies, and within these classes of therapies, we have more choices to allow pharmacokinetic and other tailoring. Now, the real take-home of precision medicine, and if you don't remember anything else, I think this title slide really is the take-home message, which is we want to improve group outcomes by optimizing each individual outcome. So let's say we have a group of patients with a type of cancer, and we treat them all with the same therapy and same dose. Some patients will do well, shown in green, and other patients may do less well, unfortunately. Now, if we had a way to differentiate, for example, how much of a receptor was overexpressed or how many, which types of receptors are overexpressed, we could tailor that therapy. So in addition to helping patients who have overexpression level or receptor A, we could also help patients now who have different expression levels by optimizing that dosing or giving different therapies. And we've done this for many years. For example, with eyeglasses to correct nearsightedness, we don't give everyone the same eyeglass prescription. We don't give everyone the same blood transfusion, we type match. And with antihypertensive, we give different doses and different types of antihypertensives. And this is also true of targeted cancer therapies. And as we have more and more targeted cancer therapies, we can now use that. We need additional information to help optimize how we couple those targeted therapies to each cancer patient. Now, when we think about the heterogeneity between all of us in cancer populations, there's really two approaches. One is a radiogenomic approach, and I know there's going to be lectures later in this meeting about that. And radiogenomic approaches really often will use anatomic or physiologic images and have a large n-value data sets. Now, they tend to be less specific for individual genetic changes, and that's because phenotype doesn't match one-to-one with genotype. But they can assess the probability of a number of different disease states. For example, on a chest CT scan, we can look for COPD, for lung cancer, for infection. And images can contribute to a large system of weighted probabilities that include electronic medical record data. And we can use that information to make multiple small increments, which sum into meaningful probability assessments. So if we have some features on a chest CT, we might be able to tell the probability or increase the probability that of knowing that there's certain mutations, for example, EGFR mutations or ALK mutations in that lung cancer. Now, molecular imaging approaches tend to be somewhat different. We tend to inject molecular targeted agents. We have a high degree of quantification of a specific target, but we have a limited number of targets that can be assessed. And imaging intensity often correlates with a specific protein or gene expression. Now, molecular imaging approaches tend to be somewhat less good for screening settings or unknown disease states, but we can often use them to characterize already identified cancers to help guide drug selection or dosing. It's really, another word for it can be companion diagnostics. And when we think about molecular imaging, how does molecular imaging help? Well, if you think about cancers, and actually many diseases, molecular processes drive disease. So we improve disease detection with higher contrast and anatomic imaging, as the ovarian cancer case I showed earlier. We can also stratify patients in terms of which targets are overexpressed and how much. And that's because targeted therapies don't work in all patients with a given type of cancer or other disease. So for example, Herceptin won't be helpful in a patient who doesn't overexpress HER2. And we can also determine if dosing of a molecularly specific therapy is adequate. Many new drugs are pathway specific and toxicity may not be dose limiting. And therefore we need a readout for dosing. And we also have an easier evaluation of combination therapy using molecular imaging. And if you're trying to optimize, for example, 3 different drugs in a drug regimen, it's easier to assess individual parameters of each drug separately, and molecular imaging can help us do that. One of the other things in cancer therapy is determining cellular response or resistance, and we can do that by, for example, imaging proliferation or looking at surrogates, for example, looking at changes in metabolism as a marker of response. Now, biopsies give us a lot of information, but repeat biopsies are not that common, except usually in phase 1 or phase 2 clinical trials. So imaging can potentially replace repeat biopsies and sampling, which aren't often feasible in regular clinical practice. So in this era of precision medicine and molecular imaging, they really dovetail to form precision imaging. Now, cancer is quite complicated, and there are multiple pathways that are involved in regulation of cell growth and making sure that cells communicate with one another. And there's a great series of papers that were published over the last 20 years by Doug Hanahan and Bob Weinberg called The Hallmarks of Cancer. And one of the real, I think, insights that they showed were that there's a number of things that make a cancer cell. So there's sustained proliferative signaling, there's evading growth suppressors, there's avoiding immune destruction, there's a number of other factors. And by using these large frameworks or these large buckets, they help provide some semblance of order on understanding how cancer signaling works. And if you look at around each of these hallmarks of cancer, there's specific drugs that have been developed to target different abnormalities in types of cancer. What's always been impressive to me is how much relevance our imaging, nuclear medicine imaging and molecular imaging, have in these understanding and being able to assess these different pathways, both for looking at abnormalities and looking at response to targeted therapies. So for example, in cell signaling and growth receptors, we can image receptor tyrosine kinases, we can image EGFR, we can image HER2, we can look at hormone receptors, for example, the estrogen receptor or androgen receptor. We commonly image the somatostatin receptor. We can also look at tumor cell energetics. We can image sugars, we can image lipids, we can image nucleic acids, we can image amino acids. We can also look at angiogenesis, looking at integrins, looking at perfusion agents. We can also look at replicative potentials, looking at DNA synthesis agents, and we also have markers of invasion and metastasis. Now, one of the nice things about FDG, which is a common downstream pathway for a lot of, even with targeted therapies, cancer cells often will change their metabolism, is that we can use that as a marker for early response assessment. So even not only for standard chemotherapies, but for also molecularly targeted chemotherapies. So in the upper left, there's BRAF inhibitors given in these patients with melanoma, and you can see very early on that there's changes in glucose metabolism. Likewise, ALK inhibitors in non-small cell lung cancer on the upper right, or P110 alpha inhibitors, part of the PI3 kinase pathway in ovarian cancer. And as all of these therapies are being developed and being used more and more in clinical trials or clinical practice, we can use standard imaging agents like FDG often to look at that downstream response assessment. And in the US, FDG, fluorodeoxyglucose, is used between 2 to 3 million times a year. Now, it's important to remember that tumors are not just cancer cells, but there's a microenvironment. So tumors are made up of tumor cells, of course, but also blood vessels, stroma, immune cells, other types of material that forms a tumor. And as part of treating and understanding cancer, we not only want to be able to image the tumor cells, for example, using things like cell receptors, prostate-specific membrane antigen, somatostatin receptor, others. We can also look at glucose or amino acid as part of looking at the tumor cells. But we have abilities to look at immune cells that are often involved in the tumor microenvironment. And that involves a number of different tracers that I'll be talking about later, including CD8 or granzyme B, reporter genes, or macrophage agents. We can also look at the host response, or the host stroma, looking at fibroblasts. So fibroblasts, when you have a wound, help with healing, but there are cancer-associated fibroblasts that have abnormalities that can may potentially make cancer cells grow faster, and there's ways to image that with fibroblast activation protein imaging agents. We can also look at blood vessels directly as well. Now, in the last 5 years, one of the areas that have really caught nuclear medicine by storm is looking at that host response, looking at the fibroblast activation protein inhibitor. And the seminal work, the early work, has been done out of Heidelberg, by the Heidelberg group, and you can see in a lot of different cancers that fibroblast activation protein inhibitor is overexpressed on the fibroblasts, which enable us to improve detection of a number of different cancers. And I believe that there's going to be a lot of benefit to understanding which cancers are imaged by FAPI, and which are better assessed by glucose metabolism, for example, by FDG. And as we grow our armamentarium of ways to image, we will need to understand when to use which imaging agent best. So as I mentioned, there's a number of different imaging agents we can use. For prostate cancer, one of the things that's really quite remarkably replaced how we've been doing imaging is using PSMA-targeted agents, prostate-specific membrane antigens, for imaging and radiotherapy. And it's basically in a number of prostate cancers, PSMA is overexpressed, and as there's neoplastic transformation, that PSMA is moved to the luminal surface, making it easier for the imaging agent to reach it and be able to then image it. It's significantly overexpressed and further increases in advanced stages of cancer. And we are doing about 10 cases of PSMA imaging a day at our institution, and it continues to grow. And I know we're going to hear a number of great talks on PSMA in this meeting, as well as not only for imaging, as well as for therapy. And just some examples, I think what's remarkable to me is it used to be that bone scans were typically performed for prostate cancer, and as time goes on, then it was replaced by fluciclovine, looking at amino acid imaging for prostate cancer. And now in a lot of the world, the gallium or fluorine PSMAs are dominating just because of the very low level of PSA levels that can be used or where imaging can be effective in detection. And the imaging agents have gotten so good with PSMA that there are whole fields of treatment that are growing because of that. So for example, because of PSMA, the concept of treating oligometastatic disease and prostate cancer is growing, as opposed to jumping straight to systemic therapy when there's a few metastatic foci. Now, in breast cancer, there are a number of abnormalities that can occur. One of the things, if there's estrogen receptor overexpression, is there are drugs that block the estrogen receptor or drugs that degrade the estrogen receptor, selective estrogen receptor degraders or SERDs. We can use an analog of estrogen to image the estrogen receptor, and we can use this potentially for optimizing dosing. So fluoroestradiol can be used for PET imaging of the estrogen receptor. This is a mouse study where it just shows that with doses of fulvestrant, which causes estrogen receptor degradation, that increasing doses cause the degradation or block of the estrogen receptor that precedes even changes in metabolism. So one of the things we want to know is if we're giving multiple drugs, how do we know we're giving the right amount? Using fluoroestradiol imaging, we can assess whether we've given enough selective estrogen receptor degrader as part of a combination of therapies. So in the patient shown pre-treatment on the left, you can see that there's a number of uptake in the bones. That osseous uptake reflects not only tumor foci, but areas where there's increased estrogen receptor expression. And with the drug that destroys the estrogen receptor, we can see that we're giving enough. You can see on treatment, we can see on the right that the foci of estrogen receptor have gone away. Now, the reason we're interested in doing that is not only to see where the tumor is, but more importantly, to know if we're giving enough of a drug. So if therapy fails, we don't know if the therapy fails because we're not giving enough of the drug or because those cancer cells don't need that pathway and have other ways to overcome that in terms of growth signaling. So here, as we escalated the doses of a selective estrogen receptor degrader, you can see that at higher doses, more of the estrogen receptor is degraded. So if the treatment fails in an individual patient, it's not because we're not giving enough. And that's a way that molecular imaging can be used for pharmacodynamic imaging and can be used for appropriate drug dosing. So now I'd like to change directions and talk about something that I'm quite interested in, which is looking at immunotherapy. Now, immunotherapy has really changed how we treat cancers in a lot of ways for many different types of cancers. And in fact, it's been so profoundly changed our landscape that the Nobel Prize for Medicine in 2018 was given to James Allison and Tasuku Honjo for their work for their discovery of cancer therapy by inhibition of negative immune regulation. Dr. Allison for CTLA-4 work and Dr. Honjo for PD-1 work. Now, tumor immunology is quite complicated, but a couple of points to remember is that there are T cells that are used to sample the environment, and what happens is there's dendritic cells, and there's the T cells get regulated in part by CTLA-4, and when the T cells interact with tumor cells, they're also regulated in part by PD-1. Those are commonly referred to as checkpoint inhibitors. Now, immunotherapy has changed oncology. It works by taking the brakes off the immune system. And there's a marked improvement in outcomes. Response rates to these therapies are significantly higher than to standard chemotherapy, and those patients that respond often can have more durable responses than with standard therapy. But it's important to remember that immuno-oncology therapy fails in most patients, and response rates are often less than 50%, depending on the regimen and tumor type. And there's a reason we have brakes on the immune system, and that's because the immune system can be in overactive states, can attack normal tissues. So there's toxic side effects, especially when you combine different checkpoint inhibitors. And we can see that in patients who are given checkpoint inhibitors that adverse events can occur in a majority of patients, and these can be quite severe or even fatal, especially in more aggressive regimens. So we need different markers to assess immunotherapy response. And there's thousands of trials. If you go to clinicaltrials.gov, you can see the trials that are involved in checkpoint inhibitors and other immuno-oncology pathway therapies. Now, one of the, as I mentioned earlier, FDG is amazing, and we use it quite a lot, millions of times a year. But in immuno-oncology, immune cells use sugar and immune cells take space, and so do tumor cells. And so as the immune cells go into a tumor, we need to differentiate whether our therapy is working and that the immune cells are just taking space. That's called pseudo-progression. So you can see here, after immunotherapy started, the tumor's gotten bigger, and other focus becomes apparent before subsequently, as the immune cells are killing the tumor, that signal goes away. Versus true progression, where tumors continue to grow. And because it's hard to differentiate these, sometimes patients are kept on inappropriate or ineffective therapy for a long time because of this concept of pseudo-progression. When I think of how to assess immunotherapy response, I think of 6 large areas. One is we can do anatomic imaging. We can get a CT scan, we can get an MR scan or ultrasound and measure a tumor, whether it's getting bigger or smaller. We can do a biopsy and look at genomics of the tumor. We can try and directly image the immune cells. We can look at CD3 or CD8, potentially even reporter genes for some immune cell therapies. We can look at metabolism, and again with the confounders that I mentioned, where glucose metabolism may reflect a combination of immune cell glucose utilization versus tumor cell utilization. We can look at immune modulators and image those. Another thing is to look at immune cell activity. That includes things like DNA analogs or looking at granzyme B. So again, as tumor cells are being killed by T cells, as the T cells interact with tumor cells, we can look at markers on the T cell itself, whether that's CD8 or reporter genes. We can look at PD-1, which is also overexpressed in this combination of the interaction of the T cells and the tumor cells. We can also look at granzyme B, and I'll be talking more about that in a minute. Some very nice work from Elizabeth de Vries's group from the Netherlands was published some years ago, where they radio-labeled an antibody for PD-L1 and looked at the uptake and used that to assess response. What was interesting is that the expression level didn't necessarily correlate with the response, but the imaging very nicely separated out progression from non-progression. So potentially a useful agent when people are getting PD-L1, anti-PD-L1 therapy. Some very nice work several years ago from Sam Gambier at Stanford used reporter genes to look at CAR Ts. These are engineered T cells, in this case targeting brain tumors, and you can see that there was higher uptake in the imaging, which reflected the infiltration of the CAR T cells in these brain tumors in these patients. So again, there's a number of ways in terms of cellular-based therapies which are gaining increasing use around the world. We can potentially use reporter genes to follow where those T cells are going. Some very nice work out of Memorial Sloan Kettering using a CD8 imaging agent, where here you can see there's a focus of tumor, melanoma in this case, And you can see here that looking at that there's CD8 infiltration. You can also see that in hepatocellular carcinomas, again, to follow where the T cells are going and when they infiltrate tumors in the setting of checkpoint inhibitor therapy. An approach that we've been interested in using is looking at active T cells, so not only looking at where the T cells go, but when they're actually actively killing tumor cells or other cells. And what granzyme B is a enzyme, is a protein inside T cells that when they interact with tumor cells, they release porphyrins, which create channels inside the tumor cells, and release granzyme B, which goes inside tumor cells and results in apoptosis. What our imaging approach does is look at the extracellular granzyme B to try and identify where those active T cells are. And we believe that granzyme B is useful not only for checkpoint inhibitor therapy, but also CAR Ts for solid tumors or even tumor vaccines, because they all have a common downstream pathway. Now, this is the last mouse picture, but I just wanted to show that you can take genetically identical mice, you can implant them with genetically identical tumors, and treat them with checkpoint inhibitors, which again take the brakes off the immune system. And some tumors respond and some tumors don't respond, and that's always impressed me. With our imaging agent, the granzyme B imaging agent, what you can see is that we're able to identify which tumors respond by increasing levels of radiotracer uptake, which again images granzyme B even before there's any changes in volume. So by doing early imaging, we can potentially see which tumors will subsequently shrink. We've taken this to patients at several different institutions around the world, and you can see here in this patient with melanoma image at Mass General that there's metastases at T10 and T12. You can see the granzyme B uptake. This patient was started on pembrolizumab, which is a PD-1 inhibitor. You can see that there's a lytic focus in this vertebral body in this patient with melanoma. You can see after treatment is started, again, monotherapy with PD-1, which is a checkpoint inhibitor. You can see that start to fill in as the tumor cells die. You can see the granzyme B radiotracer uptake at that site. One last example, which in another patient with melanoma, there was an FDG scan done at baseline, and you can see that the tumor is uniformly hot throughout the tumor, that there's high levels of FDG uptake representing high tumor glucose metabolism. We then performed a granzyme PET image. You can see that part of the tumor has high levels of granzyme B radiotracer uptake, and some have low levels. And what we predicted in real time was that areas with high granzyme B signal would subsequently respond, and areas with low granzyme B signal, unfortunately, would subsequently have less of a response. And a follow-up FDG PET exam showed that to be the case. So you can see that this area has lower FDG signal in areas with high granzyme B activity, and areas with low granzyme B activity, subsequently the tumor grew more rapidly at that site. So potentially a lot of interesting work on the horizon in terms of immuno-oncology as well. So some take-home points about precision imaging and how it relates to precision medicine. I think a framework of common abnormalities can help us take a reasonable approach between two extremes of group size. One is that every tumor is different, or all tumors from an organ should be treated the same, and the right answer is probably somewhere in between. And we can use these sets of expected signal changes to improve group outcomes by optimizing each individual outcome. For example, by treating only a subset of a population that's going to benefit from a specific therapy. And really, imaging is vital to this process of precision medicine, resulting in the need for precision imaging, which allows such individualized decision-making that can't be achieved by serum markers or biopsies alone. And so with that, thank you, and I look forward to answering questions.